Hello everyone and welcome to another APSAD Insight webinar. My name's Jim Hunt. I'm one of the nurses here with Insight, or the nurse educators I should say, with Insight. To start with, I'd like to acknowledge the traditional owners and custodians of the land on which we're meeting today, and I'd like to pay my respects to any elders past, present or emerging. And I'd like to extend that welcome and respect to any Aboriginal or Torres Strait Islanders that might be joining us today in webinar land. Today's webinar is going to be slightly different, I think, from much of our usual stuff, in the sense that many of the things that we present are things that people are already familiar with, but I think this one's going to raise awareness to an issue that some people may not have thought about. And it's presented today by Insight's own Anita Myers. She's a registered nurse that has been with us for a couple of years now. And as part of her time with us, she's been doing a lot of research around substance use, and in particular, the substance that she's going to talk about today. So without much further ado, I'm going to hand you over to Anita Myers, who's going to talk to you about quetiapine.
All right. Good morning, everyone. So as Jim said, my name's Anita, and today I am going to be talking about quetiapine. So quetiapine has been used both for a large variety of mental health conditions, as well as those with dual diagnosis and substance use, and as well as an adjunct therapy for treatment for substance use. However, there's now been growing concern that this treatment is becoming a drug of dependence in its own right. So here's my little disclaimer. This content has been developed out of the work done for the real-time reporting project that I'm currently working on. And it's primarily based off the literature evidence. So if the literature doesn't say it, then it isn't here. There's actually like a large gap between what is known as evidence-based practice and practice-based evidence. Trials require things like funding and can take time to perform and to get published. So oftentimes they can lag behind what is actually happening in practice. So I can only cover what is in literature here. If you need support for someone with quetiapine use disorder or who is withdrawing from quetiapine, then you need to be contacting your local clinical advisory service. So in Queensland, that is our ACAS service. So what is quetiapine? So quetiapine, which the brand name of is Seroquel, is a widely used atypical or second generation antipsychotic. It's available in two forms, so immediate release and extended release. So to start off, to kind of give you guys a bit of idea where quetiapine sits, I thought I'd have a look and see where it sits in the zeitgeist. And I did what all good millennials would do and looked for some memes. So it turns out that quetiapine makes you quite sleepy, or it might wake you up if you don't take it. It's for everybody. Even endometriosis. So apparently antipsychotics can be helpful for that. I did quite like the Seroquel and Chill. This next one I thought was quite poignant, just because it kind of shows where quetiapine can start to go wrong and can go wrong with a lot of other drugs that we are prescribed. So years ago, I was prescribed the drug Seroquel at a low dose to treat my severe depression. The main thing it did was drastically improve my ability to sleep. And now, because of that, I lie to my psychiatrist about still being depressed, so she won't take me off it. So sometimes, you know, we can start these medications with good intentions and trying to treat a certain thing, but then things can go awry later on. And this is not just with quetiapine, this can happen with many different medications. So a little bit of the history. Quetiapine is a dibenzothiazepine derivative. It was first patented in 1987 and then was registered for therapeutic use 10 years after that. It was developed to provide relief from mental illness whilst eliminating all the extrapyramidal side effects that were common in many of the first generation antipsychotics. So when I'm talking about these extrapyramidal side effects, for those who aren't aware, these are like drug-induced movement disorders. So they're often resulting in difficulty with voluntary control of muscles. So increased movement and involuntary contraction of muscles. So things like tardive dyskinesia, akathisia, Parkinsonism. Now, these things can be very debilitating for patients because they interfere with your social functioning, your communication, motor tasks, activities of daily living. And people would often abandon their therapy with the first generation antipsychotics as a result of this. So how does it work? So like most psychotropic medication, the exact mechanism remains poorly understood. So I kind of wanted to give you guys a bit of an idea about what this was doing to the brain, so you might be able to understand what it might be helpful for, and also what people might be looking for when they are using this outside of a prescription or misusing it. Unfortunately, it's very complicated. So in order to give you a bit of a visual representation of the depth I'm going to go to, my explanation is going to look a little bit like this lovely flower picture when I'm actually trying to explain the picture over there. So look, there's some pinks and there's some purples and there's flowers and there's trees, but it is very, very simplified version. There's huge dynamics interplay between different neurochemicals. For example, if you have a whole bunch of dopamine flooding your brain, for example, it's going to have cascading effects. It's not just dopamine that floods the brain and that's all that happens. But that can be very difficult. And even the best neurobiologists still don't really know everything. But to any neurobiologists out there or budding neurobiologists, I apologize. So how does it work? So it blocks your dopamine 1 and 2. Just if you're wondering about the 1 and 2 sort of things. So there's more than one receptor for each of these different neurochemicals, and they're categorized. They occur in different concentrations in the brain, so we'll have slightly different effects. It is also a potent blocker of your serotonin 2A or 5-HT, which is serotonin. It will partially antagonize or increase your serotonin 1A. It's got antihistamine effects. It blocks your alpha 1 and 2 receptor, and it increases activity at the sigma receptors. So that all sounds very fancy, but what does that mean? So for dopamine. So dopamine antagonism, or the reduction of dopamine transition, this kind of works off a dopamine hypothesis, which broadly states that an increase of activity of dopamine, particularly at the mesocortical and mesolimbic pathways, is associated with symptoms of schizophrenia. Now, it is far more complicated than just increased dopamine equals schizophrenic symptoms. There's also downregulation in certain areas, particularly the prefrontal cortex, has also been associated with that. And again, our understanding of this is still emerging. But that's very simplistically so. The other thing with quetiapine is it's also got what's called a fast disassociation from the dopamine, which essentially means that it's blocking the dopamine action, but it gets kicked off pretty easily by other dopamine. Which has been linked to one of the reasons why it has reduced extrapyramidal side effects. So how does it work in regarding to this serotonin antagonism? So this serotonin antagonism, it is the dopamine antagonistic effect. So this blocking of dopamine across a range of pathways, because you can't be specific. So wherever there's D1 and D2 in the brain, it's going to block it. Even if it's fast disassociation of it, it's still blocking it. But it's this blocking that can give you the extrapyramidal side effects. What they've found is that blocking the serotonin 2A seems to stimulate dopamine release in a range of pathways. So you kind of had this antagonistic effect between the two. So this reduces the side effects of a typical dopamine blocker. And it's the ratio of the dopamine versus the serotonin 2A that results in a medication being classed as atypical. So the higher the serotonin 2A, the fewer the effects. Again, more complicated than that, but it's very simplistically. So across other neurotransmitters, so the partial serotonin 1A agonism is responsible for its antidepressant and anti-anxiety effects. It's antihistamine, that makes it a hypnotic, a sedative, and also is responsible for its appetite promoting effects. It's alpha-1 antagonist, so theoretically it is increasing dopamine in the striatum and then will lead to decreased extrapyramidal side effects, but also dropping your adrenaline will result in some anti-anxiety effects. The alpha-2 blocking, this mediates dopamine again in the prefrontal cortex, which is supposed to improve cognition. Although the alpha-2 antagonism in quetiapine is actually lower than some of the other atypical antipsychotics. And a sigma-1 agonist. Now, this is probably the least understood. It seems to have an effect through multiple different neurotransmission pathways, including glutamate, cholinergic, serotonin transmission. But essentially, they think that stimulating that is giving some antidepressant effects. So how does it work in its metabolites? So there's one major active metabolite of quetiapine, which I'll go into a little bit later, but it's called norquetiapine. So it has a higher affinity to your serotonin 1A receptor, which leading to antidepressant effects, but also to your acetylcholine receptors, leading to anticholinergic effect. Now, these anticholinergic effects are actually side effects we don't want. So they can increase pupil size, increase heart rate, constipation, give you difficulty urinating, impaired concentration, confusion, attention deficit, and memory impairment. Now, there is a disagreement, depending on where you read and who you talk to, about the anticholinergic risk from quetiapine, although the risk obviously is going to be higher in the higher dose. So if you're taking a whack load of it, you're going to have a higher risk of it. So it should be looked for in overdoses. But also, it just means that caution needs to be used for elderly patients, so they should have lower doses. Now, if I have hurt your head talking about all these different neurotransmitters, and you want to find more about them, we've actually made a video resource that is available on our website that explains many of these different neurochemicals if you kind of want to go back and get a bit more of an understanding about what the heck I was talking about. So how does it work across the different doses? So at a lower dose, at the 25 milligrams, it's a histamine 1 and alpha 1 receptor blocker. So essentially it's giving you a lot of sedative and anxiolytic effects seem to predominate in that lower dose. As you go up between 50 to 200 milligrams, seems to be more antagonizing those serotonin receptors, leading to its antidepressant effects. And in doses over 300 milligrams, this is when it really starts to have an effect on those dopamine receptors and giving you those antipsychotic effects. So a little bit on the pharmacokinetics. It is metabolized by your P450 system, which is your major metabolizer in the liver. It's done by CYP3A4 predominantly, and to a lesser extent, 2D6 and 2C9. Its major metabolite is norquetiapine. So immediate release formulations reach maximum plasma concentrations at about an hour post-ingestion, with the extended release having a peak plasma at about 6 hours afterwards. So the elimination half-life of quetiapine is 7 hours, regardless of whether it's immediate or extended release, and 12 hours for its active metabolite. The extended release formulations, they do appear to have a lower peak plasma concentration and have less sedative effects. Now, in saying all of this, concentrations are going to be affected by other medications they're on and other substances that are metabolized by the same pathways, particularly the CYP3A4. So these are things like your azole antifungals, so things like fluconazole, or your proton pump inhibitors, so omeprazole and pantoprazole. There's also going to be genetic differences and age-related changes as well. So quetiapine has generally been considered and been sold as like other antipsychotic drugs, is generally considered to be devoid of abuse potential. So essentially when they marketed them and they brought them out, said, well, nobody is going to misuse these. They're not going to get anything from it. These are safe drugs. They're good drugs. However, there has been quite a growth of prescribing. So there was a rapid increase in prescription rates. The latest Australian PBS data from 2015, which is the last time that they made a report on the data, showed a 285-fold increase in prescribing of quetiapine since 2000. The highest increase was actually at the low dose, so between 25 and 100 milligrams. Now, this 25 milligrams was actually made by the drug companies as an elderly dose. Due to those pharmacokinetic changes, that was an elderly dose, yet we seem to be having one of the biggest growths in that area. And there were immediate release versions, which they believe were being used for off-label indications. Now, what I mean by off-label indications or off-label prescribing, this is where something is not indicated for use by the Therapeutic Goods Administration. So any prescription medication, they will say, this is what we think you should use this for. But the medication is known to have desirable treatment effects for other conditions. Again, this is where the TGA and research can be quite slow to catch up what is actually happening and what is working in practice. They did find, however, in 2010 that the manufacturer had to pay $250 million in the US following government allegations of misconduct around its promotion of its off-label use. Now, without getting too political in this, essentially the drug company was found to be overstating how effective quetiapine was for its off-label use, and then were fined as a result of that. This doesn't seem to have had a huge effect on the amount of prescribing or the off-label prescribing, with up to 60 to 70% of patients being treated in the US being used quetiapine off-label. So why is this a problem? Like, does it really matter whether we're doing this off-label or not off-label? Much of the misuse and non-prescribed quetiapine comes as a result of diversion. So the easier it is to get, then the easier it is to divert. So what is it approved for? So it has TGA approval for immediate release for bipolar affective disorder, including treatment for manic and depressive episodes, and treatment of schizophrenia. And the extended release is also for bipolar affective disorder and schizophrenia, but as well as treatment for major depressive disorder for those who are either unable to or have had a poor response to alternative therapies for the treatment of, for its treatment. Also, it can be used for generalized anxiety disorder. The recommended maximum dose is 800 milligrams. So what is it used off-label for? Insomnia, generally at low doses. Again, this is where you're getting those histamine effects at those lower doses. For other anxiety disorders, including but not limited to things like OCD or PTSD. For ADHD, so to help with some of the stimulant side effects. For psychosis and behavioural disturbances in dementia. Psychosis in Parkinson's disease, eating disorders, and borderline personality disorders. So one of the major driving forces behind increased quetiapine prescriptions is its use as a hypnotic or to help you sleep, which is arguably, although nobody in literature actually outright states it, it's arguably due to people's concerns about prescribing benzodiazepines. So they're worried about things like dependence and misuse of benzos. So we've gone, oh, great, we'll just give them quetiapine because that's a safe drug. It's devoid of abuse potential, so it's fine. About 1 in every 3 people, so for those who want to know, number needed to harm is 3, experience sedation. So generally speaking, when it's used for what it's indicated for, the sedation isn't a good thing. So it's called harm as opposed to treat. There's actually a lack of evidence for its efficacy and safety in its use to support its use in insomnia. And whilst it's not always the case, and some people might stay on 25 to 50 milligrams for many years, there are actually cases of people having to increase the dose to get that sedative effect. The Australian guidelines for the treatment of insomnia advise against the use of an anti-psychotic for the management of insomnia. So how is it used in substance use? So there's actually this increased dopamine in the prefrontal cortex, coupled with hypnotic and anti-anxiety properties, have been resulted in quetiapine used off-label for the treatment for substance use disorders, both in aiding its withdrawal as well as maintaining abstinence. Now, the evidence I'm going to present here is on its efficacy is based off the published evidence. Again, there's going to be quite a big gap between what's actually happening in practice at the moment and what evidence says is effective or not effective, but this is the best that I have. So these results are from a number of small studies, both in patients with and without comorbid mental health conditions, with patients with comorbid conditions generally having the greatest improvement. So for alcohol use disorder, it's actually been shown to decrease alcohol intake, reduce craving, increase sedation, and improving sleep quality and reducing anxiety. And the results were maintained even in cases where people chose to continue to drink, obviously at lower levels. However, these positive results weren't universal across all the studies. There's also been shown to be in some animal studies a reduction in some of the withdrawal symptoms from alcohol. And it doesn't seem to have the same seizure threshold reduction like other antipsychotics. So this is just something in alcohol withdrawal that it's a little bit of a contentious issue, that there should always be some caution in using any antipsychotic therapy in alcohol withdrawal, as it may increase the risk of seizures by dropping your seizure threshold, and you've got that increased risk. Although theoretically benzodiazepines should mitigate that, but again, it's a contentious issue, but quetiapine doesn't seem to have that same seizure threshold lowering effect. It's also been used in opioid withdrawal, so it's used to reduce anxiety, pain and cravings, as well as used as an adjunct to help people with persistent pain during an opioid detox. So they found that if they're trying to drop somebody's opioid dose, if they're trying to wean them down or change them over, that quetiapine seems to help reduce the amount of pain relief that they require. It's also been used in cannabis use disorder. So they found that people with quetiapine reduced their use. The studies that I found weren't quite specific as to what led to that or what they thought led to that. They essentially just said they did diaries before and after and said, well, they're saying they're using less. For amphetamine use disorder, so there's been improvement in depression, sleep, cognitive function, even in ongoing use. And in fact, there was an animal study, which I thought was quite interesting, that showed that there was improvement in methamphetamine-induced cognitive deficits by taking Seroquel as well. Cocaine use disorder, they've shown that there's decreased craving and a reduction in use, although this wasn't consistent. Again, the studies seem to contradict themselves a little bit. So one said it worked, one said it didn't. In polysubstance use, they showed that it was used to decrease anxiety, insomnia, agitation, and obsessional symptoms. The one thing that I couldn't find that I thought that they potentially would have got more on was its use in benzodiazepine withdrawal. Theoretically, it's got sedative and anti-anxiety properties that would indicate that it might be useful if you're trying to come off benzodiazepines, but I couldn't actually find a study to say that when I was looking for benzodiazepine use disorder. So, but it potentially may be useful in that, although you may be swapping one thing for another. So how is it used when it's not prescribed in substance use? So its street names are Quell, Suzy Q, baby heroin, snoozeberries, squirrel. I found on some of the drug forums I was looking at, people were referring to it as getting snowed. Its routes of administration, they're pretty much the same as you would have for any substance. So you can take it orally in low or high doses, snort it, IV, smoke it, or rectally administer it. The highest use was in incarcerated populations and those who use other substances. So often quetiapine is used in polysubstance use rather than just on its own. It's difficult to estimate the exact numbers. So the IRDS was sort of saying about 9% of injecting drug users, and the ERDS was saying about 7% of substance users were using non-prescribed antipsychotic medication. So when I tried to sort of dig a bit deeper as to what percentage of people that might be, I found another study that's saying about 60% of second-generation antipsychotics that were being misused were quetiapine. Though I think that's probably a little bit of an underestimate. Because up until 2019, ERDS and IRDS, they only used the word Seroquel, not antipsychotic. And there wasn't a great change in the percentage across those years. There's also evidence that it was commonly being misused amongst some methadone maintenance programs. The dose. So it's a little difficult to tell. So there are case reports of people having up to and over 2,000 milligrams. I think I found the highest was about 2.4 grams. I had a look on Blue Light, which is one of the drug forums, to sort of see what doses people were talking about. And they were having anywhere from 25 milligrams to help come off stimulants to 1,400. So it can be, some of the reasons people use it is to assist with getting high or as a downer to mediate the effects of stimulants. It's primarily used to self-medicate rather than for euphoria. So again, I had a bit of a deep dive on some of the forums, and people seem pretty against its use as a substance in and of itself. Just the kicks. They were saying it was better for use as a self-medicating or use with other substances. So some of the reasons that the research seems to think that people are, or it says that people are using it, is to self-medicate for insomnia, self-medicate for anxiety, to get drunk without the hangover, to reduce the crash of stimulants, to zone out, to take the edge off, to isolate themselves from the prison surroundings, to substitute for other substances when they can't get it, and to calm anxiety post-substance use. Again, theoretically, although the literature doesn't quite say it, because it's not routinely used or checked for in urine drug screens, people that either for their work or as part of like probation and parole may also be using it as a substitute for other substances, particularly if they liked those more sedative medications, because it's not routinely screened for, so it gets around that. So it's used in the opioid treatment programs. So with the article I found that was talking about its use in methadone programs, although there is evidence that would suggest that quetiapine pharmacokinetically increases the serum levels of methadone, and therefore you would potentially get more methadone by its pathway of the CYP2D6. They actually found, when talking to the people that were using it, that it was predominantly mixed with other sedative medications rather than methadone. So it seems to be more, again, people that prefer that sedative effect prefer to use it with other sedatives. There was actually one case report of a person using quetiapine to potentiate a high from their Suboxone, but it was one case report. So how accurate that is or isn't, how representative it is of the greater population remains to be seen. So what is exactly happening in the brain? Again, it's poorly understood. I refer you back to my beautiful attempt at Monet's Garden of Giverny. I'm going to be very, very basic here. So there seems to be some sort of interplay between the serotonergic, noradrenaline, dopamine, and cholinergic systems. So one mechanism, there was lots of theories. Depending on the paper, I'd find a different theory. One of the theories was that because it's a potent antihistamine, which means it's, that is not being mediated by the blocking of the dopamine 1 and dopamine 2 due to the quetiapine's lower affinity than it does for the histamine. This is resulting in increased dopaminergic activity. And particularly it seems in quetiapine that it has more effect in the nucleus accumbens than it would with other second generation antipsychotics. And the nucleus accumbens has been linked with other addictive processes. So There is also animal studies that show that having the co-administration of quetiapine with amphetamine resulted with these anti-anxiety effects, but didn't have any effect on the reward properties that they were getting with the amphetamine. So it's kind of like you can have all the fun of the amphetamine without any of the anxiety issues that you might otherwise have. There were other animal studies that indicate that the reinforcement from the use of quetiapine, even by itself, was enough to result in repeated self-administration. So again, if we go back to studies from many, many years ago when they were looking at things like morphine, you know, the rats preferred the morphine water, the rats seemed to prefer the quetiapine water as well. So what is some of the harms from quetiapine use? So with its misuse, some of the side effects include things like sedation. Again, we've got that one is, you know, 1 in every 3 getting sedative effects. It's even higher here. Tachycardia or increased heart rate, slurred speech, dizziness, drop in blood pressure, agitation and irritability, confusion, difficulty walking, nausea, seizures, dropping in your respiratory output, and coma. So what are some of the harms, the longer term harms from quetiapine use? So even if quetiapine is therapeutically indicated, it's still associated with significant risks. So there is the cardiovascular risk. There's an increased risk of prolongation of something called your QTc or QT interval, which essentially the bigger that gets, it increases your risk of arrhythmias that may be fatal. And this seems to be, for quetiapine, the highest risk is actually in people that have other medication that will also prolong this interval. Orthostatic or postural hypotension. So essentially when you stand up, your blood pressure drops, which can increase your risk of falls. And metabolic factors. So weight gain in particular, again, some of the memes that I found when I was having a bit of a dig, there were lots of ones about quetiapine and making you eat a lot. So weight gain is one of the biggest ones, as well as elevated plasma triglycerides and cholesterol, so increasing your heart disease risk, and more rarely hypoglycemia, so high blood sugar, which can occur, and all of these can occur even if quetiapine is at lower doses. And despite the fact that there's lots of things that are going to prevent these extrapyramidal side effects from occurring, they can still occur in about 10% of people taking quetiapine. One of the other harms you can get is obviously overdoses. So overdoses from second generation antipsychotics in general are considered relatively mild. However, there has been a documented increase in mortality from quetiapine with a 7.4-fold increase in quetiapine associated deaths in Victoria, which is where most of the research has come out of about quetiapine, over a 10-year period ending in 2016. However, nationally, there's also been sharp increases in deaths with marked increases since 2013. So if you have a look at the graph below, there is sort of some higher lines around earlier than that, particularly the Tasmania and Northern Territory. However, so this is from the Pennington Institute with their overdose report. So they kind of say that some of those high doses, the higher lines earlier on, it's a small population, so there's a lot higher error in the per 1,000 people. But since 2013, there seems to be a nice rise across all the states and territories. 2017, slightly lower. Again, because coronial data takes a while to come through to work out whether or not it was actually quetiapine involved or not, they've dropped off, but they seem to suggest it will probably also be higher. So the poisonings as well are also increasing. So there was a 6-fold increase in quetiapine related calls over a 10-year period in Victoria. And it's the 5th most called about medication. Of all the medications people are calling to the poisons line about, they're calling about quetiapine. And a Melbourne toxicology department showed that 9% of all referrals, so they take all substances and all overdoses, were quetiapine related. So the most common formulations they found in these overdoses were less than 100 milligram tablets. And 56% of the presentations, they were able to identify as definitively off-label or non-PBS approved prescribing indications, with just over half being co-ingested with other substances. So about 75% of people had co-ingested benzodiazepines with them. I think opioids was next at about 50%, methamphetamines 45%, and cannabis a little bit lower than that. I liked the next graph just because it kind of shows that you have a nice increase. The prescription rate goes up, so does your overdose, as does your mortality. So with these overdoses, the symptoms of toxicity occur between 1 to 2 hours post-ingestion, although this will be longer for the extended release formulations unless they're chewed, in which case it will be like their immediate release ones. So once that peak plasma level starts to hit at about 1 to 2 hours, this is when you're really going to start to see the overdose. So these symptoms include sedation, slurred speech, seizures, coma, those anticholinergic effects that I spoke about earlier. So blood vision, dry mouth, constipation, urinary retention, agitation. We'll also give them sinus tachycardia, so fast heartbeat, as well as potentially that prolonged QT interval, which again can increase your risk of fatal arrhythmias, and a drop in blood pressure. Now, however, the co-ingestion with other substances, including alcohol, is going to alter these symptoms somewhat. So particularly it will have a synergistic effect. So if you're having quetiapine with, say, benzos, which is one of the highest co-administrators, then you're going to double the amount of sedation that you're going to get. So the treatment from this, it's largely supportive. So essentially you're treating the symptoms that they come with. So you stabilize the airway, the breathing, the circulation. They might need intubating and other medications to help with that. They have suggested, there wasn't a lot of suggestion from the guidelines above that. They said that you can give them benztropine for the extrapyramidal side effects if they get them, and using benzodiazepines if they've got any anticholinergic induced agitation. So one of the other harms that you can get is obviously dependence. So like all psychotropic medication, any abrupt interruption of supply or reduction in dose will cause these discontinuation or withdrawal effects. So it's the same if it's an antidepressant or any other medication like that psychotropic medication that you're on, or methamphetamine will do the same sort of, will give you that withdrawal effect. Now, there's a number of case reports that would indicate that quetiapine has this withdrawal syndrome. However, there was limited information on the occurrence of it, with only a handful of cases actually discussing it. So there's not really a great consensus of what is exactly in it. Now, the description that I'm going to give you is based off both the drug information gathered, as well as a systematic review that looked at different case series and case reports about what was in this quetiapine withdrawal. So sometimes particularly case series and case reports are going to look at the more interesting symptoms rather than the ones that everybody will get, because that's how they're getting them published. So according to the product information, the incidence of symptoms from suddenly stopping was about 16%, although this is not based on super therapeutic doses. So this is based off that you're not having any more than 800 milligrams in a day. So if somebody's having 2 grams a day, then their symptoms may be different from, or higher or worse than what is the studies that the drug companies have done have said. So immediate release preparations have higher association with withdrawal symptoms than extended release. So the other issue with quetiapine withdrawal is that there are confounding symptoms. So because it's been used or may have been used to treat mental health issues, then it is having therapeutic value as well as withdrawal value. So it could result in relapse of condition, so not relapse of substance use, but relapse of condition. So return of the episode that prompted the drug treatment in the first place. So if you had a primary insomnia and then you've been taking quetiapine for a long time for it, then is it a withdrawal symptom if they suddenly stop it, or is it just returning to you had primary insomnia and we have never really treated it, we've just given you something to mask it? So reoccurrence is when it's the same thing as a relapse, but it occurs later. A rebound is a return of the original symptoms with a greater intensity. So then we have withdrawal, which is that physiological and psychological responses, and something called a persistent post-withdrawal syndrome. So it's got more intense return to the original disorder with potentially new symptoms after you've stopped this medication. So having a look through that literature review, which if somebody wants to know my exact search, I can send it to them later. So some of the common ones, so the common physical ones seem to be nausea, diarrhea, vomiting, headache, dizziness, sweating, and tachycardia. For the psychiatric symptoms, these are things like insomnia and sleep disturbances was quite marked. Anxiety, unsettled, nervous, restlessness, irritability and agitation, dysphoria or low mood, and craving for quetiapine. Some of the more infrequent ones, ones there's only 1 or 2 case reports about, were things like fatigue, back pain, fever, these hyperkinetic movements. So this is an involuntary or irregular jerking of movement that the person doesn't seem to have much control over. Tremors, high blood pressure, and palpitations. So time period. So this time period, I kind of want to give you a bit of a representation of what it might look like. The exact curve of it will be different. It's probably not exactly this. This was just a visual representation because unfortunately the data was very inconsistent or just not available at all. So onset from what I found within 1 or 2 days, things like the insomnia, anxiety, irritability, nausea, vomiting, sweating, headache, dizziness, tachycardia if you're going to get it, those hyperkinetic movements if you're going to get them, and high blood pressure. And these symptoms seem to resolve within a week. So things like insomnia, anxiety, all the same sorts of ones. Now, these symptoms that may persist, there are still symptoms that may persist, even if you gradually taper them off. So getting restlessness, irritability, and quetiapine cravings and sleep disturbances, they still occurred, even if you gradually tapered them off it. So how to manage quetiapine withdrawal. There's very little evidence on its management. So in the first instance, tapering over 1 to 2 weeks is advisable. Although, again, if they're on a very high dose, then you might want to slower the taper, or the slower you go, the less symptoms they're going to get, and it would make the withdrawal more manageable. The only recommendation I could find was prochlorpromazine or Stemetil for nausea. Now, my big public service announcement. This is, when I'm talking about withdrawal here, this is only for off-label use. So if you're discontinuing chronic anti-psychotic therapy in patients with schizophrenia or bipolar disorder or depression, then you might need to decrease this very, very gradually over months to even years with close monitoring to allow detection of the prodromal symptoms or the disease reoccurrence from coming back. So it's not something that you can just stop if they are using it for if it is prescribed for and being used for what it is therapeutically indicated for. And as always, it is recommended that if you do have somebody that is misusing it and you want more help with withdrawal or with withdrawal symptoms, then please contact your local clinical advisory service. So quetiapine, is it helpful? Is it hazardous? Firstly, more research is needed, particularly to clarify what populations of people are going to best benefit from use of quetiapine, particularly in its use in substance use or dual diagnosis. So a lot of the studies that I found, particularly its use in substance use, they were more than 10 years old. So there's not been a lot of research in that area, and more is needed. So there's some preliminary evidence that would suggest that quetiapine's anti-anxiety and sedative effects and increased dopamine activity in the prefrontal cortex can be helpful, particularly if you've got that comorbid substance use and mental health condition. But on the other hand, there's also evidence of risk of misuse, significant side effects, and overdose risk. So, like all medications, it's neither really good or bad. but it's arguably not any safer or not the safe alternative to a benzodiazepine. So really, judicious prescribing will keep in mind and tries to avoid any potential risks that will help alleviate many of the harms from this medication is going to be the best way forward. So using things like stage supply or trialing the medication to see if it's helpful first, and getting specialist involvement in early. So if I've piqued anybody's interest and they want to find out more about where quetiapine sits, so these 3 articles are ones that I used quite a lot of, and they give a nice, well-rounded view of where quetiapine and the concerns are of quetiapine at the moment. And I have all of my references if anybody's interested in reading them up. Are there any questions?
We firstly thank you very much, Anita. You know, I've been a alcohol and other drug clinician for many years and have known about quetiapine being used by our clients for many years. But I've got to say, this is the first time I've actually seen a presentation concerning that issue. So thank you very much for a well thought out presentation, and also thank you for bearing with us when we were having the technical difficulties. And again, I'd pass that thank you on to everyone that stuck with us. We really appreciate that. I do have a few questions. The first one was, you talked about the difference between authorised use and off-label use, essentially. Mm-hmm. Could you just clarify if it's used for any of the substances that you talked about? Is that off-label? That's
off-label, yeah. So that's not, so they're quite a narrow, the TGA has quite a narrow lists of what it can be used for. So doctors can prescribe any medication technically for pretty much anything, but it would be off-label use for that.
Cool. I also had lots of comments, which I shall read some of those out because I think they're valuable for other people to know. Another question, you talked about the illicit use of it, or what our guys might use or how they use it, and you talked about the different routes. So do you know, is quetiapine water soluble?
Don't know that off the top of my head.
Okay, I actually know just from my old practice that it's partially water soluble. There is a quetiapine fumarate, which is a more water soluble form, but generally quetiapine can be dissolved in water partially, so you don't need to apply any heat if anyone is doing that. Somebody's commented that up in North Queensland, Seroquel or quetiapine use has such a high value that for many people they actually barter Seroquel for their methamphetamine that they use, which I think many of us are aware of that sort of action happening. You had a slide which talked about the harms from quetiapine. Were they specifically just related to mono use, i.e. quetiapine on its own? Then they weren't harms in association with any other use?
No, that was, so again, if you're mixing anything, you're going to exponentially increase the harms, and it's a little difficult to point out exactly what those harms will be, because you will have the synergistic effects of drugs as well as its different metabolizing effects.
You obviously talked about the maximum daily authorised prescribed amount that's been up to 800 milligrams a day. Do we have any idea what our guys might be using when they're using it in their use with methamphetamine or any other drug that they're using?
So if you're using it as a downer, again, so some of the case reports sort of had up to 2.4 grams. As sort of the higher end of the dose. There seems to be, again, it depends on what you're using it for. So if you're using it more as to get that high, then they will take those high doses. But a lot of people, particularly on the forums, they're like, don't waste your time. You're only on about 25 milligrams. That's going to be enough to get you off your methamphetamine. So will be lower doses if it is just to help mitigate or as a downer off methamphetamine.
Thank you. Somebody made the comment that the adverse effects have a very similar profile to the overdose effects of taking quetiapine. Mm-hmm. And how would you know which is which? I'm guessing that it's probably less important than that you'd manage what was in front of you, but I'll let you.
Yeah, so again, the overdose or the harms are pretty much supportive management. So there's not much that you can actually do once they've taken it. It's just making sure that if they're having the tachycardia, that you might give them extra fluids or things to try and slow it down. Or, if they're agitated, if they're only a little bit agitated, then you might just move them into a room by themselves, or, try and sort of a low stimulus environment. Whereas if they're very, very agitated, then they might need some sort of more chemical sedation.
And I guess that building on to that, another comment that came through was with many of our clients being polysubstance users and quetiapine just being one of the substances that they might be using. When you have those symptoms, how do you differentiate? How do you know which drug is causing which?
Well, you don't always know. So I also work in an emergency department, and I've seen quite a number of overdoses of polysubstances. And again, mostly it is that supportive management. So you are monitoring their airway, their breathing, circulation, trying to keep them safe, because there isn't actually a medication to reverse it. So it's not like an opioid overdose that you give them naloxone and it will just fix it. There isn't actually anything you can do that will just stop the quetiapine from happening. You just have to write it out.
Thank you. One other question, which I'm pretty sure you might not know the answer to, is are there any kickbacks from the drug companies for doctors to prescribe this that would show why it's suddenly been prescribed way more? Or?
Well, so I think I sort of indicated that in the US in particular, I'm not sure over here, that I think they were very heavily promoting it. And to the fact that if the government is taking them to court over it, then I would suggest they've probably been very heavily and potentially with kickbacks over there. And sometimes when you're prescribing things, if you're hearing it from one person that this is really good or this is safe, and you're searching for those different alternatives. So things like benzodiazepines being quite, a growing concern about that. So I can't prescribe a benzodiazepine. So, I know I've got this other alternative that I've heard it's good for sleep. I've seen case reports or even the drug company showing me all of these small studies that they've done that, getting other doctors to say that it's really good. That, this is my safe alternative. This is going to work. So I'll just give them this because it's not a benzodiazepine. So I think that's some of the problem with these prescribed medications is we get very good or bad as opposed to knowing what the risks are and working with those risks. So finding out the populations that it does work for and ones that it doesn't work for, and just being as safe as you can.
And I think, somebody's also added that supportive therapy needs to be included in that as well. And I think we would all agree with that. The pharmacology side of it is only one side of it, and it's all about that rat park stuff when you're working with our clients. So definitely the supportive stuff needs to be built alongside. Do you know what the LD50 is? And for those that don't know what LD50 is, that's if you gave that dose to 100 people, 50% of them would pass away or decease as a result of that dose. Do you know what that is for quetiapine?
No.
No, and unfortunately I don't know that, but I
think it's generally considered safe. So as I said, I think the LD50, and again, I would have to look it up and I could probably find that, is potentially quite high. It's more that people seem to be mixing it with other things. So its use with other opioids or benzodiazepines in particular seem to be increasing its risk of overdose rather than just its overdose in and of itself.